Hello, everyone. Thank you for coming. Welcome to NAHDO's 40th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsors. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find more information about them and find game tokens. Game tokens are key words or phrases used in the token hunt game for a chance to win prizes in the daily drawings. Now, let me turn the stage over to Charles Hawley, NAHDO's Director of Projects. Charles, the stage is yours.
I'm muted, aren't I?
Yeah.
That's trouble, isn't it? That's my bad. I apologize, everyone. So thank you all for being here and joining the session as I talk on mute, doing regular technology stuff. It's a pleasure to be here with you despite my hokiness. This session, Fast and the Curious, Turbocharging Healthcare Value with Model Shifts, Network Pit Stops, and Caregiver Power, was organized by Angela Taylor, who will be today's moderator. And the session is sponsored by Comagin Health. We'd like to give a big shout out and special thanks to all our friends at Comagin for their generous support as sponsors. And then let me bring Angela to the stage as your moderator. Hi, Angela.
Hi.
Thank you.
Thank you. Hi, good afternoon. I will admit that the title's a little corny, and yes, I'm definitely going to lean into it. But if we can have a little fun while talking about data, then why are we even here? So, welcome everyone to Fast and Curious, the session where data isn't just along for the ride, it's behind the wheel. We've got 3 street racers in the driver's seat today, each tuning their engines for maximum impact. You'll hear how they're speeding up surgery shifts, tracking down phantom providers, and putting family caregivers right where the care happens, in the driver's seat. So buckle up. We're taking a coast-to-coast run through Colorado, Massachusetts, and Arizona. First on the line, armed with GIS mapping and Medicaid data, tracking down phantom providers haunting Colorado's network directories, revealing who's really on the road to delivering care. Please welcome Street Racer number 1, Jaime Ransohoff.
Hello everyone, and welcome to another presentation at NAHDO, assessing the effects of phantom providers on network adequacy in Colorado. My name is Jaime Ransohoff, and I am your presenter from Human Services Research Institute, also known as HSRI. Behind this project is our research team, as well as the Colorado Department of Healthcare Policy and Financing team, which was led by Sandy. HSRI serves as the data warehouse vendor for Colorado's All Payers Claims database through the Center for Improving Value in Healthcare, also known as CIVIC, and we have had the wonderful opportunity to work with the Colorado Department of Healthcare Policy and Financing on this project. Our agenda for today will cover our research approach, methods for defining phantom providers in time and distance, our key findings, considerations for future analyses, and exciting next steps for Colorado HCPF. We have a lot to cover today, so we will be moving quickly, but please feel free to reach out if you have further questions or bring them up during the Q&A. A little bit of background for this project. HSRI and HCPF worked together to explore HCPF's behavioral health provider network in Colorado, with special focuses on phantom providers and behavioral health. We'll go through some definitions, including network adequacy, which refers to whether a health plan contracts with a sufficient number and type of providers to meet the needs of plan members. And then phantom providers are providers who are contracted with a plan but do not serve plan members. And they present numerous challenges, including burdening members in their search for a provider, impeding oversight, and creating misleading impressions of network access. As much as 1/3 to 1/2 of providers may be phantom providers. So there's a lot of variation across states in measuring ease of access to care, but driving time and distance is a common one. Here we have some examples of time and distance standards for a few provider types. In Colorado, the standards vary by whether a county is urban, rural, or frontier. Key breakdowns of interest included organizational regions, also known as regional accountability entities, and managed care organizations, as well as urban, rural, and frontier areas to match the standards from the last slide. And at the time of this study, there were 7 managed care entities, which we referred to as regional accountability entities, and 1 managed care organization. So our research questions for this analysis were: first, how many of the contracted Medicaid behavioral health providers were phantom providers? Second, what provider types are phantom and where? Third, how many enrolled members have access to contracted non-phantom behavioral health providers within the network adequacy standards? And finally, what is the effect of phantom providers on meeting behavioral health network adequacy standards? Our data sources included contracted provider and member enrollment data, behavioral health encounter files, SUD fee-for-service files, and non-SUD fee-for-service files from the Colorado APCD, also known as CIVIC. Now let's discuss defining phantom providers. Since it is just after Halloween, we did add a few ghosts in the corner here to add a little holiday spirit. But in this analysis, we defined phantom provider as a HCPF contracted provider with no service encounters to members during the study period, which was just a year. And we did look at phantom providers for both primary care and behavioral health so that we could compare the two. We also examined the location of phantom providers and their effect on meeting standards. I could have had 10 slides describing our time and distance methods for this project, but I've done my best to narrow it down to 2. We used ArcGIS Desktop with StreetMap Premium, R, and Python to complete the project. In order to calculate average driving time from patient to providers for each region of interest, like the RAYs in each county, we used a modified origin-destination cost matrix. What is an origin-destination cost matrix? It's a geostatistical function that calculates the driving time and or distance between a set of origins, or starting locations, and a set of quote-unquote destinations, or ending locations. In our case, the origins were members and the destinations were providers. So, depending on its size, origin-destination cost matrix can take an extremely large amount of computing power and a really long time because it must calculate a route from every member to every provider. So calculating the entire OD cost matrix was really not feasible in this case. Instead, we determined as a team that to calculate compliance with HCPF standards, we would only need to calculate the driving time and distance from each member to 2 providers for each provider type that we were studying. First, their nearest provider, and second, their nearest non-phantom provider, which is sometimes the same provider as in number 1. Though this was still computationally intensive, the method was significantly less intensive than doing the whole cost matrix would have been. So how did we achieve this modified matrix? Here's a flowchart of our methods, which you can feel free to check out in more detail after the presentation. As you can see, it's still pretty computationally intensive, or at least methodologically intensive. However, it's much less so than doing a cost matrix for every member to every provider. For the iteration steps, we used Python, and to obtain the original files, we used R. Then, of course, we used ArcGIS to run the matrix itself. Overall, 21.5% of contracted providers are phantom, which is lower than what we found in other states. 21,405 providers were included in this analysis, of which 4,605 were phantom. And as you can see, there was little variation across the rays. This table shows the percent of members within standards, including and excluding phantom providers for behavioral health specialists. The highlighted cells in this table show any difference in percentage of members meeting standards when including or excluding phantom providers, and where there are differences, they are extremely minor. Therefore, we found that phantom providers do not inflate compliance with time and distance standards. In considering future analyses, we suggested broadening the definition for phantom providers to include underutilized providers, identifying whether a small number of practitioners serve a disproportionately large number of members, using a follow-up routing study to determine the impact of standards on those who rely on public transport, and considering additional methods such as location allocation and secret shopper studies. So finally, we have some exciting next steps for Colorado and HCPF. First, secret shopper activities will now be a requirement per CMS in the future, specifically auditing provider directory accuracy and appointment wait time. Second, the Colorado National Provider Identifier Law dictates that there should only be one NPI per organizational healthcare provider service location, which is being implemented now. That will make some of the geostatistical analyses a little easier in the future. And considering the full continuum of behavioral health care, what is the right mix and capacity for a network catchment service area? This is just an area that HCPF is focusing on, including screening, community-based programs and services, outpatient services, high-intensity outpatient services, residential services, and inpatient services on this sort of continuum. This is a final quick slide that I put together of additional useful time and distance methods that we used or considered using in this work. And I don't quite have time to go through this in depth, but please feel free to take a look and let us know if you have any questions. And finally, I just wanted to thank you for taking the time to watch this presentation, and on to the next panelist.
Hi, Jaime. Great presentation. Phantom providers are something that we're looking at here in Kentucky too. And while we give the audience a moment to formulate and type in their questions, I have a couple for you. One is, would you mind defining a location allocation analysis and how it would be helpful in the context of network analysis?
Sure. Yeah, so location allocation analyses are more often used in almost commercial settings. So if you had, say, like a bunch of Home Depots and you wanted to figure out where to put a new Home Depot, you might take all the locations of the Home Depots and all of the Ace Hardwares, your competitors, and figure out where there were the most people who didn't have access to like a hardware store. And maybe think about putting a Home Depot there. And so a location allocation analysis like that can be really helpful in the context of network analysis because you can do the same thing with providers. So if there's a certain number of inpatient psych providers, in an area, you can kind of see where there's a demonstrated need for that service, and there aren't that many like non-phantom providers. So you might think about looking for an inpatient psych provider to contract with in an area like that. That's an example of another geostatistical analysis that could be useful for, network analysis.
So my next question is, phantom provider sounds almost cinematic, so that fits right with our with our theme here. So, but obviously that there are real world consequences. Were there any surprises in how many there were, or where they were concentrated, where the ghost providers were mostly concentrated?
Yeah, well, I think one thing that we found was that there were a good number of phantom providers in urban areas, which was interesting. But it could also indicate that that provider just weren't approached by a member during the year, or that there were maybe even more providers contracted that were necessary, like an oversupply in the really urban areas. And that's just something that we looked into in our report a little more.
Okay. There's a question from the audience. Cindy is asking if she is curious if you shared the results with health plans and if they had any feedback for you.
Well, we work directly with HCPF, and so we shared it with HCPF, who may have then gone and shared it internally with their regional accountability entities and their MCO, but we don't know what came from those conversations.
And I have one more question. There's not a whole lot coming in from the audience yet, so I just want to make sure that I give them adequate time. We will be bringing you back at the end as well. So if you have questions for Jaime, please continue to put them in the chat, and we'll get back to her later. But if the states could fix one thing to improve their network adequacy monitoring, what would it be?
I think I really think that I might be biased because I love doing geostatistical work, but I think that incorporating these more advanced geostatistical functions into looking at their network was really helpful in this project and for HCPF. I think there might be some audience members from HCPF in the audience, so if you think that was helpful, feel free to comment. But I think that might be a missing piece that more states could look into when doing phantom provider network analyses.
Okay, thank you, Jaime. That was, again, a great presentation. We'll be bringing you back out later. And like I said, if you have more questions for Jaime, please put them in the chat, and we'll make sure that she gets to those one at the end of the presentation. So the next street racer is tracking the hospital to outpatient shift through Massachusetts APCD and discharge data, spotting where surgeries are switching lanes and what that means for efficiencies. Ooh, excuse me, got tongue tied there, on the road ahead. Please welcome street racer number 2, Katya, Fonkych.
Good morning, everyone. I'm excited to share our research on how surgery site of care shifts affect spending in Massachusetts. Health Policy Commission regularly tracks the drivers of healthcare costs. Recently, we found that inpatient spending is slowing, while outpatient spending, especially surgeries, is rising fast. Just in 5 years, from 2019 to 2023, outpatient surgery spending per member grew 41%. We suspected that surgeries moving to outpatient settings explained both the inpatient decline and the outpatient growth. So our goals for this research is to identify which surgeries shifted, whether the shift saved money for the Commonwealth, and how it affected hospital capacity. For this research, we used 2 data sources: the acute hospital discharge data set covering all payer inpatient data, and the all payer claims database covering medical claims for commercial and Medicaid claims for 2019 through 2023 time period. This chart uses inpatient discharge data for all payers and shows the trends in scheduled surgeries versus all other inpatient stays during the last decade. Scheduled non-emergency surgeries were 16% of all discharges in 2016, but had been on the decline from the beginning of the period. When the pandemic hit in 2000, they dropped another 20% in just 1 year, and then continued to gradually decline after that. In total, scheduled surgery volume fell 38% since 2016, freeing roughly 2.9% of total bed capacity, or about 366 beds statewide. Most of the decline, around 70%, was in orthopedic surgeries, like joint and spine procedures. We suspected these didn't disappear, but moved to outpatient settings, which inpatient data alone could not confirm. So to test that, we turn to the EPCD, which captures both inpatient and outpatient claims. We grouped inpatient professional and facility claims into stays using the same DRG version for all the years. We also created surgical encounters by grouping all claims for the same patient, same day, where the most expensive procedure was a major surgery using HRQ definition of surgery types. Because inpatient and outpatient coding systems differ, we manually matched categories to ensure that we were comparing similar surgeries using the combination of clinical classification software categories, DRGs for inpatient, and individual procedure definitions. At the end, we focused on 20 candidate surgery groups that showed at least 10% outpatient growth were cited in prior research. To ensure comparability to outpatient surgeries, we limited inpatient cases to shorter length of stay of 4 days or fewer. The results presented here focus on commercial surgeries, although Medicaid results were quite similar. Of the 20 surgeries that we considered, 9 showed a clear shift to outpatient, meaning outpatient share grew more than 8%. For example, hip replacements increased from 20% to 88% in outpatient, and hysterectomies from 80% to 88%. Other procedures like tonsillectomies or hernia repairs were already mostly outpatient by 2019. This means the major phase of shifting had already occurred, suggesting that inpatient decline might be tapering off by now. The 9 selected surgeries account for about half of the entire outpatient surgical spending growth since 2019. It's not only shift in setting, overall utilization increased as well. Orthopedic surgeries increased 15 to 24% depending on surgery, suggesting greater access of provider-induced demand as outpatient sites expanded. Utilization of obesity surgery, although, fell by about 18%, likely due to rising use of GLP-1 medications for weight loss. Across the board, outpatient surgeries were much cheaper than inpatient ones, anywhere from 22% lower for hysterectomies or 65% lower for spinal fusions. For major joint replacements, outpatient procedures cost about 40% less. Despite of our effort to maximize comparability, part of those sizable price differences might still reflect lower complexity and healthier patients in outpatient setting. This slide shows how commercial hip and knee replacements shifted sites between 2019 and 2023. In 2019, 82% were inpatient, with only 4% in ASCs and the rest in hospital outpatient departments. By 2023, the picture flipped, with 85% becoming outpatient, of those 50% going to general acute care hospitals and another 16% to an orthopedic hospital in Massachusetts. ASC utilization expanded rapidly and accounted for about 17% of these surgeries, with at least half of that volume provided out of state. Regardless of site, outpatient prices are lower than inpatient, but surprisingly, ASC prices are often similar to hospital outpatient department rates. Notably, our orthopedic specialty hospital that used to provide a quarter of these surgeries didn't fully recover its volume on the outpatient side. Inpatient prices for hip replacements grew modestly, about 11%, while outpatient prices stayed flat. The average spending per surgery, which is yellow line in the middle of the chart, fell from about $31,000 in 2019 to $24,000 in 2023, which is a 23% decline, purely from the shift to lower cost settings. Had no shift occurred, average spending would have been about $10,000 higher per surgery, which is represented by dashed blue line on the chart. This is unusual in healthcare, where prices typically rise, but growing competition from new outpatient options seems to have kept prices stable even as complexity increased in both settings. Using hip and knee replacements as examples, the shift to outpatient saved about 30% per surgery, or $10,000. Even if we assume that all increased utilization of about 20% per member was driven by outpatient shift, the savings would still remain substantial at 11%. Those savings could have been even greater than measured if we consider that increased outpatient options might have depressed the price growth. So in a decade between 2016 and 2025, scheduled inpatient surgeries fell 38%, freeing about 366 hospital beds. We identified 9 surgeries in this research driving most of that shift, which are mainly orthopedic and some male and female system procedures. While outpatient surgery spending per member rose 41%, roughly half of that growth comes from those 9 surgeries moving to outpatient and not new or pricier surgical services. That shift generated sizable savings, up to 30% per surgery for both commercial and public payers. However, most shiftable surgeries are now at least 80% in the outpatient setting, so further decline will slow down. And although these shifts save the system money, they constrain some hospitals' finances, which lose their inpatient revenue without gaining enough outpatient volume. To conclude, shifting surgeries to outpatient settings has helped slow healthcare spending growth in Massachusetts while expanding access to care. Thank you for your time, and I look forward to your questions and discussion.
Hi, Katya.
Hi.
Great presentation. I was really, when I read your abstract, I was so excited to see this presentation. I think it's just such a neat study. There are some audience questions, but I would like to sneak one of mine in first, and that is, are there additional data sources or alternative ways to measure and analyze inpatient to outpatient surgery shift?
Definitely. I really wish we had in Massachusetts ambulatory surgery data set, which would be an analog of hospital inpatient data set that we use at the start of our study. That one would cover all the payers, like truly all payers, because as many of us know, APCD is not covering many commercial payers, and sometimes APCDs don't have all Medicare patients. So we were not able to fully see a comprehensive picture of how hospitals lost the entire inpatient volume and whether or not they regained that volume on the outpatient side for all the payers, and truly see the impact on those providers. But many other states have that data. 33 states submit ambulatory surgery data into the national sample of ambulatory surgeries combined by HCAP into a single national data set. And in addition, California has their own, and probably a couple of other states, they have a more comprehensive ambulatory surgery data sets that also collect AC data, because the HCAP ambulatory surgery data set does not cover that. They only cover hospital outpatient departments. So having that data would make this analysis much, much easier and also more comprehensive. So if other states have that data set, my advice would be just start by using that one.
Yeah, we have that in Kentucky. So this next question is actually really pretty apropos for us specifically. But Kenneth Odell is asking, would you expect your findings from Massachusetts to be similar in other states or different?
Oh, that's a good question. In some ways, Massachusetts is different because until 2017, we had ACs, new ACs were not allowed to be opened for our regulatory environment. And it changed right before pandemic hit, so there was another delay. So most likely we did not have a lot of shift, at least prior to pandemic. And it's possible that other states without any barriers to opening new ACs, had more shift to ACs earlier, before 2020. And secondly, in terms of the impact of shifting surgeries to outpatient, I think Massachusetts was different because we had a lot of inpatient, a lot of hospitals closing during this period. And lately we had, because of the whole steward system fall down, we lost a couple of hospitals. So we don't really have excess capacity. This outpatient surgery shift freed up inpatient beds, but we didn't really feel it because we lost a couple of hospitals. And in other states where like hospital capacity stayed stable, maybe this shift generated excess capacity, and maybe some hospitals would be seeking to like fill their inpatient beds with, I don't know, maybe sometimes induced like provider induced care, or admitting more patients from emergency room or some other ways. But we don't have that pressure in Massachusetts. We actually shorten capacity.
Okay. Michael Lawson is asking, you mentioned that the complexity of the inpatient and outpatient surgeries increased due to shift, and we should expect higher prices. Why is that?
Well, this is because outpatient surgeries are usually less complex to begin with. And when new AC opens or new surgery is being provided at a hospital, at first they start treating only the least complex cases. So the complexity is really low. But as time goes by, more and more complex surgeries shift from inpatient to outpatient. So the complexity of outpatient surgeries should increase over time, especially when the whole like share reaches like 90%. It should be like very, very close to what it was originally on the inpatient side. So we really should see the pressure on prices, on like average price of the surgery to go up, not only because over time prices go up, but also because complexity is increasing. And the same thing on the inpatient side, like as surgeries leave, less complex surgeries and shorter length of stay surgeries leave inpatient setting, the ones that are complex remain, and the complexity also increase. So it was like really, really unusual for us to see that outpatient surgery prices for hip and knee replacements, they stayed almost flat throughout the period.
Okay, and then Stefan has a question. As you think about the cost of the Commonwealth, are you able to consider the extent to which this loss of revenue drives facilities to maximize facility fee charges in outpatient settings?
Well, first of all, what we saw is that the prices in the outpatient settings didn't change very much, and our prices, the way we measure them, they include both facility part and professional part. And it seems like some of these surgeries, because they're like now there are also ACs that provide them, they become competitive, and it is like a highly profitable service, relatively speaking. So many hospitals want to attract those surgeries. So there, I think, out of all services in healthcare space, those might be some of the most competitive, and there might be some competitive pressures that are keeping both facility fees and overall prices down. But sure, like everybody, they feel the drop in revenue. The revenue for most facilities drop just because inpatient prices are higher than outpatient, even if they were able to keep their entire outpatient volume. But many of them lose their outpatient volume to
ASCs in Massachusetts or out of state.
Thank you, Katya. If you have additional questions for Katya, please keep putting them in the chat, and we'll bring her back at the end for the full panel questions. Thank you very much. As we our last racer is exploring how Arizona's family caregiver licensed health aid program is putting family members in the fast lane of hands-on care. Please welcome street racer number 3, Nathan Pauly.
All right. Thank you all for being here today. My name is Nathan Pauly. I'm a senior manager at Manatt based out of our San Francisco office, and very happy to be here virtually today to share some preliminary findings from our analysis assessing the impact of the Arizona Medicaid Family Caregiver Licensed Health Aid Program. I'll just start out by sharing a little bit more on the background and objectives for this analysis. In April 2022, Arizona Medicaid began covering Family Licensed Health Aid, or LHA, services. These services allow family members of medically fragile children to become licensed and paid to provide skilled nursing care. The launch of this program in Arizona was very important. Prior to the LHA program, medically fragile children in Arizona were eligible to receive private duty nursing, or PDN, services. Now, historically, many children authorized to receive PDN services in Arizona haven't been able to receive the full array of services authorized due to widespread workforce shortages. The launch of the LHA program, which allows family caregivers to provide care within the home, could allow for more consistent in-home care and could eventually lead to improved health outcomes and reduced costs for these medically fragile children. With that in mind, we set out with this study with 2 objectives. First and foremost, we wanted to assess the impact of the LHA program in Arizona by comparing measures of healthcare resource utilization and outcomes among children that started receiving LHA services after the program launched in April 2022, relative to children receiving traditional PDN services alone. More broadly, we are seeking to build an evidence base for the effectiveness of Medicaid cover family LHA programs to support ongoing advocacy efforts among the home care community. Go into a little bit more background on the data source and methodology we used for this analysis. For this analysis, we leveraged a data source called the Transformed Medicaid Statistical Information System, or TMSIS, analytic files, or TAF data. We used TAF data from 2021 to 2023 to compare measures of healthcare resource use, or HCRU, and outcomes among children initiating LHA services relative to children receiving traditional PDN services alone in Arizona. The TAF data essentially represent the national repository of Medicaid claims and enrollment data. These data include comprehensive beneficiary level Medicaid enrollment, fee-for-service claims, and managed care encounter data from all state Medicaid programs. Our analysis focused on Medicaid-enrolled children under the age of 21 in Arizona who received at least one LHA or PDN service from April 2022 through June 2023. For this analysis, we developed 2 distinct cohorts, including an LHA cohort, as well as a cohort of children that received PDN services alone. The LHA cohort included children who may or may not have been previously receiving PDN services, but started receiving LHA services after the program launched in April 2022. Our cohort of PDN children were children who were only receiving PDN services throughout the study period. Children in both cohorts were assigned an index date based on the date of their first LHA or PDN service after April 1st, 2022. Individuals were required to be continuously enrolled in Arizona Medicaid for 6 months preceding and 6 months following their assigned index date. The 6 months preceding an individual's index date was classified as that individual's baseline period, and the 6 months following an individual's index date was classified as their follow-up period. We started by assessing differences in baseline demographic and clinical characteristics among the 2 cohorts using basic descriptive statistics. We then compared measures of healthcare resource use and outcomes among each cohort's baseline and follow-up periods. Some of the key measures we were looking at included things like rates of emergency department visits and inpatient hospitalizations, length of stay associated with inpatient hospitalizations, as well as adverse events like infections. We used paired t-tests and McNemar's tests to assess whether or not individuals had statistically significant differences in terms of rates of healthcare resource use and outcomes in follow-up periods relative to baseline periods. We were happy to find promising initial evidence that the Arizona LHA program may be associated with reduced likelihood of emergency department visits and inpatient hospitalizations relative to receipt of PDN services alone. I'm not going to have time to go through all of our findings in detail today, and we'll just hit on a few highlights. Ultimately, we ended up including 90 individuals in our LHA cohort and just over 500 individuals in our PDN cohort. In our initial baseline comparisons, we found that the LHA and PDN cohorts were generally similar in terms of baseline demographic and clinical characteristics. We found that the LHA cohort had a significantly greater proportion of patients who were female, as well as a significantly greater number of patients who had gastrointestinal disorders. But other than that, we didn't identify statistically significant differences between the two cohorts. One of the things that we were interested in looking at was rates of PDN service use among individuals in the LHA cohort to assess whether or not LHA services may be replacing utilization of PDN services. Here, we did find that individuals in the LHA cohort were significantly less likely to receive PDN services in their follow-up period relative to their baseline period, with 63% of individuals in the LHA cohort receiving PDN services in their baseline period and only 51% receiving PDN services in their follow-up period. This suggests that for some services, utilization of LHA services may be replacing utilization of PDN services. I want to draw folks' attention to some of our findings looking at rates of inpatient hospitalizations and emergency department visits. If you look at the left-hand side of this slide, this figure is showing rates of inpatient hospitalizations and emergency department visits among the LHA and PDN cohorts in the baseline and follow-up periods. When we looked at inpatient hospitalizations among the LHA cohort, we identified a sizable decrease in the likelihood of inpatient hospitalizations, with 22% of patients in the LHA cohort having an inpatient hospitalization in their baseline period, relative to only 14% having an inpatient hospitalization during their follow-up period. Among the PDN cohort, rates of inpatient hospitalizations were essentially the same during both baseline and follow-up periods, with 27% of children in the PDN cohort having an inpatient hospitalization in their baseline period and 26% having an inpatient hospitalization among their follow-up period. When we looked at rates of ED visits, we did find that individuals in the LHA cohort were significantly less likely to have emergency department visits in the follow-up period relative to the baseline period, with 43% of individuals in the LHA cohort having an emergency department visit in their baseline period relative to only 31% having an emergency department visit in their follow-up period. Again, among the PDN cohort, we again here saw that rates of emergency department visits were essentially the same in patients' baseline period and follow-up periods. These results make sense because for the PDN cohort, nothing really changed. Many of these children were receiving PDN services prior to their index date and continued to only receive PDN services following their index date. We are happy to find that these preliminary results may underscore the potential benefits of the family LHA program in Arizona. This study was not without limitations. So this analysis only focused on the LHA program in Arizona, and results may not be generalizable to other states with similar programs. The study was also hampered by the recent launch of the LHA program. The program launched in April 2022, and this analysis only leveraged data through 2023 because these were the most recent data available at the time the study was conducted. This did limit our ability to follow patients over a long period of time and did ultimately impact the number of individuals that we were able to include in the LHA cohort. The study was also subject to several external confounders. So first, results from this analysis may have been impacted by changes in PDN or LHA service use associated with the COVID-19 public health emergency. Arizona also launched a second program during the COVID-19 public health emergency called the Parents as Paid Caregivers program, which may have impacted measures of HCRU and outcomes assessed in this study. Finally, the statistical analyses that we conducted for this study did not adjust for individual level demographic or clinical characteristics or receipt of other services that may have impacted measures of HCRU and outcomes. While these findings are preliminary, it does open up several directions for future research. So first and foremost, additional research is needed leveraging more recent data that will allow us to assess longer-term impacts of the LHA program and will hopefully allow us to identify a larger sample of LHA patients. Future research should also include development of more robust statistical models that can adjust for individual level characteristics and receipt of other services that could impact measures of healthcare resource use and outcomes. I want to finalize by just acknowledging the support of Team Select Home Care, which is a national home-based provider organization that provided funding to support this study, as well as our analytic partners at HCCI, the Healthcare Cost Institute, that provided analytic support. Thank you so much.
Hi, Nathan.
Hey, Angela.
I love this presentation. I think this is such a neat thing, and it's such a great job. Well done. Again, I'm going to give some people time to put their questions in the chat, but I do have one for you, and that is it possible that the LHA and PDN populations are just dramatically different in terms of like need and severity?
Yeah, Angela, that's a great question, and something that we were very cognizant of as we embarked on this analysis. We know there are some other states where both PDN and LHA services are available, and in some states, the eligibility criteria for LHA and PDN services are really different. So in some states that we thought about doing an analysis like this in, we knew that we would be sort of comparing apples and oranges if we were trying to compare a population of LHA patients to a population of PDN patients. Arizona was really an ideal state for this kind of analysis, though, because the eligibility criteria for LHA and PDN services in Arizona are the same. So every patient that is eligible for PDN services in Arizona is also eligible for LHA services. And it's not like we would expect one population to be much sicker than the other. We did look at baseline clinical characteristics of the two populations and saw that the populations were generally similar in terms of rates of a lot of different chronic conditions. We saw that rates of ventilator use and tracheostomy use were relatively similar between the two populations. So we felt like we were comparing two populations that had similar levels of patient severity. But also we can't adjust for everything. And there could be some baseline differences. We've heard some feedback from the stakeholder community that given the familial nature of LHA services, these are services provided by family caregivers, that there could be differences within the family, like maybe parents or caregivers are a little bit more willing or able to provide care to their children if they're receiving LHA services. That could imply some differences in access or utilization. But overall, we felt like the two populations were pretty similar.
Okay. Kenneth has a question. Did you look at differences in the number of service hours authorized versus utilized among those two populations?
Yeah, that's a great question too, and that's something that we really wanted to look at. So there's often this idea in the sort of home caregiver community that these types of family caregiver services can help ensure that patients are able to receive the full scope of authorized services. We often see cases where patients may be authorized to receive, say, 60 hours of PDN services a week, but because of provider workforce shortages, they're only able to receive maybe 30 of those authorized hours. And so we really wanted to compare sort of that number of hours utilized versus authorized. But unfortunately, in the claims data, we don't have access to information on the number of authorized services. So we are working on some separate analyses where we're looking at sort of persistent receipt of care and trying to look at the number of patients who are persistent recipients of services throughout a year and looking at sort of a proportion of days covered measure to see whether or not there are differences in terms of consistency of service receipt across the two populations.
All right, and then Michael has a question. He's asking, the caregiver model you studied seems to improve outcomes and efficiency. What's the most important ingredient for making that sustainable long term?
That's a great question, Michael. I mean, so I think first and foremost, we need Medicaid agencies to be willing to sort of cover these services. For some Medicaid programs, this is going to be a new sort of model where you have these kinds of family caregivers who are trained and authorized to provide these services. And so I think one of the most important things for making that sustainable is having support available for these family caregivers. There needs to be standardized training programs and programs in place to make sure that they are doing everything that they need to do. We need to have monitoring and oversight in place to ensure that they're providing the services, in fidelity with the model as intended. So I think that sort of support for the family caregivers is going to be really important, but also think that we just need to be doing more research like this. This is very preliminary, and so we don't want to make it sound like this study is the be all end all, like LHA services are better than PDN services. It's really going to depend on the child and sort of their family situation, which service is best for a given individual. So I think additional research is going to help too, to help us understand sort of where this model can be most successful in the long term.
We're really looking forward to future analysis on this. It's a really interesting project. So obviously incredible insights from everyone here, but let's open up the garage and bring our racers back and open up the chat to questions. And while they're coming out, it's become sort of my own personal NAHDO tradition to bore you guys with a really bad dad joke. So here it comes. What do you call it when a driver finally gets exactly what they deserve? Karma.
That's great.
I said it was bad. All right. While we're waiting for questions, I have one for all of you, for the whole panel. Were there any findings in your analysis that challenged your expectations? Like something that your intuition, the data told you that your intuition didn't?
I can go first. I think I mean, so getting back to like the first question that we had about differences between the LHA and PDN population, I honestly expected there to be more differences. The fact that the populations looked so similar in terms of different measures of clinical severity made us feel better about the analysis that we were doing. But also, if you look at some of our preliminary results, when we looked at baseline measures of inpatient hospitalizations and emergency department visits, the LHA and PDN populations were almost exactly the same in terms of baseline rates of inpatient hospitalizations and emergency department visits, which I think was surprising to me, because we sort of expected there to be some differences in terms of the patients that started taking advantage of this program once it was launched.
Katya, anything in your data that surprised you?
Well, I already brought it up during my presentation, but the biggest surprise was the lack of price growth, which I expected to see for multiple reasons, like complexity increase and just in general, like our prices in Massachusetts kept rising, like inpatient prices on average increased like 17%, outpatient prices about 15 to 20%. And here we don't see much price growth, and that was like a really surprising finding. So which made me want to do a further exploration, like are like really competitive forces that are keeping the prices down. And another thing was that we kind of expected our main orthopedics hospital to pick up most of outpatient surgeries, to be like at the forefront of this inpatient to outpatient shift. But data told us that they were actually behind, and they, at least from what we can see in APCD, without having like full commercial population, just looking at Medicaid population and full insured commercial, we saw that they actually lost patients, like total orthopedic patients. So that was another surprising find.
And Jaime, what about you?
Yeah, I found it interesting that phantom providers, like the presence of phantom providers, affected member to provider ratio and other like administrative stuff more than it affected driving time, and whether or not someone was in driving time or distance standards. Oh, I meant and average driving time. So if your closest provider is phantom, then you have to drive farther to find one that's not phantom. But like within 30 minutes, if you have two providers within 30 minutes of you, more than likely one of them is not going to be phantom. So I found that pretty interesting.
Thank you. All right, 3 states, 3 engines, 1 mission to make healthcare data move smarter, faster, and further. So thank you all for allowing me to lean into this theme. Thank you to our incredible drivers, Jaime, Katya, Nathan. and to all of you in the audience for riding along. And of course, to our great host, Charles, and to CoMagine Health. We'll pass it back to Charles now.
Yes, I'm just going to echo appreciation. Thank you, Angela, for organizing and moderating this session. Wait, first, am I on mute? No, I'm not. Good news. And especially your dedication to themes. Theme dad jokes are a whole new level. And thank you to our presenters, Jaime, Katya, and Nathan. Of course, many thanks to the session sponsor, CoMagine Health, and all of you for joining us here. Next up is the State Showcase, Policy Insights, Market Dynamics, and Care Model at Models, maybe plural, at 4 o'clock Eastern, so the top of the hour. I hope to see you all over there.
Thank you.